House Healthcare Committee, March 27th. And this morning, we're going to spend some time on S28, an act relating to the access to certain legally protected healthcare services. And the first person up is Mike Fisher. Mike, if you could introduce yourself, we'll get going.
Happy to. Good morning.
Good morning.
Mike Fisher, healthcare advocate.
Morning.
So the Office of the Healthcare Advocate supports S28 as passed by the Senate. We don't have any particular concerns or areas where we think there needs to be adjustment. And just on a very high level, I think it strikes a good balance at protecting healthcare workers who are providing care, legally protected care, and protecting the public from misleading or advertising intentionally designed to mislead the public. I really want to express appreciation for VAZ and for the Medical Society and others who, along with the Senate, did the lion's share of the lifting on this.
Excuse me.
Happening behind me.
Black.
Question?
Fine. There you go.
And just state clearly for the record that the Healthcare Advocates Office tracked this bill. We did express support for it in the Senate, but I don't want to take credit for things that we didn't do. We saw it going in a good direction, and as we monitored it, we were able to provide support for it in the Senate. But the lion's share of the lift happened from other providers, from other advocates. I guess I also just want to spend just a moment recognizing the discussion about the adaptive questionnaire. And you've heard from my office over the years some level of concern about quality. We noted this and spent some time really looking at it and looking at the evidence, and landed at the place that I think you heard most clearly from the Medical Society, that the outcomes appear to be as safe and effective as other approaches to providing medication for abortion services. And so we are in support of that section as well. But I want to recognize that that came with some independent analysis from us. So we wanted to double check around patient safety. So, thank you.
Welcome, Mike.
Thank you.
Thank you for your help as well. Any questions from the committee? Questions, you get out of easy. All right, thank you, Mike.
Thank you. Have a great morning.
Now we have Sharon Tilbury. Sharon, if you'd come up and introduce yourself to the committee. We already know you, but this is for the people out watching.
Sorry, we need to move these flowers because they're blocking. Look at the beautiful as they are, and I love flowers. Of course you do.
Good morning. For the record, my name is Sharon Toborg. I'm policy analyst for the Vermont Right to Life Committee. And I thank the committee for inviting me here today to address S28. Unlike the other witnesses you've heard from, we do have some concerns with certain parts of the bill. First off, in section 3, that section amends language contained in Act 15, which became law less than 2 years ago in May of 2023. Act 15 included provisions specifically targeting pro-life pregnancy resource centers for regulation because they do not provide or refer for abortions. I don't know if you're aware, but those provisions of that law are currently being challenged in court as unconstitutional. The case is in federal district court. It was brought by the National Institute of Life Advocates and 2 of the pregnancy centers located here in Vermont. Excuse me. Oral arguments were heard by Judge Sessions, who rejected the state's request to dismiss the case in toto. And his decision stated that, quote, the Pregnancy Resource Center stated a plausible claim for violations of First Amendment rights. Instead of addressing those First Amendment concerns, however, S28 kind of doubles down, expanding the state's unconstitutional regulation of speech and opening it up to additional costly litigation. Even though this bill's title refers to legally protected healthcare, it's important to note that S28 defines all advertising about healthcare services, any healthcare service, by any person as commercial speech, even if there's no economic motivation underlying the speech. In addition, it employs a very broad definition of advertising, which would capture an individual's social media posts, their comments in a letter to the editor, something they might say if they called into a radio program. It could even affect a politician's campaign materials because it regulates all speech related to healthcare by any person. And courts have ruled that you cannot just declare speech to be commercial speech in order to regulate it, which is basically what this bill does. That was also an issue that Judge Sessions addressed in some of his comments. You can't just say, yeah, speech is commercial because you want to regulate it. And I do want to be clear that the Vermont Right to Life Committee does not disseminate advertising that is untrue or misleading. And the other organizations with which we partner do not either. However, we are acutely aware that the Attorney General, who is responsible for enforcing this law and levying potentially $10,000 fines on our organization, is a staunch abortion advocate. And the abortion lobby labels many claims about abortion that they don't like to have spoken as untrue or misleading. And we'll consider one topic this committee dealt with a couple years ago, and that is the topic of abortion pill reversal. Act 15 declared it unprofessional conduct for healthcare providers regulated by the Office of Professional Regulation to provide or claim to provide services or medications that purport to reverse the effects of a medication abortion. However, there is evidence that the abortion pill reversal protocols developed by medical providers can safely be used to try and reverse the effects of the first abortion drug in the two-drug medication abortion. But that provision was still added to Act 15 at the last minute at the request of Planned Parenthood. The abortion pill reversal protocols have been used successfully over 5,000 times, saving the lives of unborn children and protecting a woman's right to change her mind and carry her pregnancy to term. But under S28, if pro-life advocates want to inform women about abortion pill reversal or perhaps hold a sign like they do during the 40 Days for Life campaign, with a QR code to connect people to abortion pill reversal, we would be put at risk because obviously the state disagrees with us, as is evidenced by the law passed 2 years ago, that this is a valid medical procedure. And we believe that this language is yet another attempt by the state to chill the speech of pro-life advocates and others whose opinions on a wide range of healthcare topics are politically unfavorable at this moment. And I would also note that this committee looked at adding the provisions regarding misleading healthcare advertising to every medical provider's unprofessional conduct standards separately. So I think that the concerns around medical providers providing untrue or misleading information have been addressed. And I would urge the committee to repeal Section 2493 and allow Vermonters to speak freely about medical issues without concerns about $10,000 fines. The next section I'd like to address is Section 6, concerning changes to the availability of fetal death reports for criminal or civil cases, such as assault or medical malpractice. Currently, Vermont law states that fetal death certificates are for statistical purposes and are not public records. When S-28 was introduced in the Senate, it included an additional line saying that they would be confidential. But Senate Health and Welfare, at the last minute, without discussion or any testimony, added that the report shall not be disclosed or discoverable in any civil, criminal, administrative, or other proceeding. With so much focus on protecting abortion here in our state house, some forget that Vermont also protects a woman's right to carry a pregnancy to term. The report of fetal death provides vital information that could enable a woman to hold a person who causes the death of her unborn child through negligence or violence accountable. In fact, under current law, if there is evidence of violence or unusual or suspicious circumstances surrounding the fetal death, the medical examiner is to be notified to investigate and complete the medical portion of the fetal death report. But under the language proposed in S-28, I don't even know if the fetal death report would be kept confidential, even from the child's parents. And if so, if that could prevent them from seeking justice. And finally, S-28 would further the trend of lowering standards for providers of so-called legally protected health care. The legislature has already done so under Act 15, allowing providers of so-called legally protected health care to treat patients via telehealth in other states, even if they are not licensed to practice in those states. That action would be considered unprofessional conduct for any other provider of any other type of healthcare. And in S-28, there's another carve-out allowing certain providers to prescribe abortion pills based on an electronically administered adaptive questionnaire, which would continue to be inadequate and unprofessional conduct if used to provide any other medical service. And it's important to note that there is not necessarily any patient doctor connection between the provider and the person filling out the questionnaire. This lack of face-to-face interaction not only makes evaluating the patient's responses to the health questions more challenging, it also allows individuals to obtain abortion pills for criminal and abusive use, as has recently been alleged in Louisiana. A mother allegedly obtained abortion pills from a New York doctor via an online questionnaire, and on receiving them, coerced her pregnant 17-year-old daughter into taking them. According to officials, the daughter wanted to keep her baby and was planning a gender reveal party. And the teen's mother has been charged with criminal abortion by means of abortion-inducing drugs. And there are also many cases of men secretly giving abortion drugs to their pregnant partner or coercing them into taking the pills. Eliminating any face-to-face interaction with the prescriber will make it easier for men to obtain pills for nefarious purposes. The increasing ease of obtaining abortion pills suggests that the risks of taking them are minor. And I know you've heard testimony that the outcomes are similar between in-person prescription and online prescription. However, just because the results are the same doesn't mean that there are not serious side effects that need to be considered. Medication abortion has a complication rate 4 times that of surgical abortion, and up to 20% of women will experience a complication. These complications can be extremely serious, including incomplete abortion requiring surgical follow-up, infection, and hemorrhage. Complications increase later in pregnancy the abortion drugs are taken. And I think it's interesting to note that even though the abortion pill is currently approved for use up to 10 weeks of pregnancy, in 2022, Vermont Vital Statistics reported that there were 3 instances where it was used in 21 weeks of pregnancy or later to induce an abortion. So when we talk about standards of care Yeah, that's very concerning. We hear that providers have to uphold the standard of care, but here we have some evidence that suggests that there are providers in Vermont already ignoring the standard of care and using the abortion pill much further into pregnancy than it is approved for. Certain providers should not be granted an exception to the usual standards of professional conduct and allowed to prescribe abortion pills without face-to-face interaction and creating a bona fide physician-patient relationship. The risks of the drug for the women are serious and must be clearly explained, and the risk of deception to obtain the drugs must be minimized. And we would encourage that the provisions that allow prescription via questionnaire be struck from the bill.
First of all, I want to apologize. I was in the Senate. I just have a really quick question, and then of course you can continue, but I missed the beginning, and I apologize that I missed the beginning. So are you a physician or?
I'm not a physician.
Writer?
No, I'm not.
Okay, you were just giving some information, some facts around.
The
medical.
I will submit my citations.
Okay, so you have
The committee.
reviewed research and.
Yes.
Okay, all right, great, thank you. Does anyone have any questions? Yes, Daisy?
Are you
That was
finished?
mine.
Wait,
I want to make sure you're,
My prepared comments are finished. I'm happy to answer any questions.
all right. Well, thank you very much for joining us.
thank you, Sharon.
I'm sorry, where are we on the, I apologize, everyone. Papa, why don't you continue on?
All right.
You're doing a great job.
Next, we have Allison. Yes, Patty?
I used to be a Walsh. It was much easier. Stuffy's a little more difficult. I never had to spell my last name. Yes, thank you for having me. Allison Despathy. You have me listed as a parent. I live in Danville, Vermont. I also wanted to share that I've for 25 years taught biology, nutrition, and wellness for life at the Vermont State Colleges. And I also have a Master's of Science in Clinical Human Nutrition, and I have a practice in St. Johnsbury for 25 years, which has given me access to tens of thousands of students and people that I work with who work with providers across the board. So I see people who have naturopaths, osteopaths, medical doctors. Sorry, what are the? Thank you. That's the one. Thank you. Yes. Nurse practitioners, physician's assistants all across the board. And what my concerns are on S28 are options. People need options. That is the bottom line, in my opinion, and in my experience. And I work with, again, students and all of the people in my practice, and every single one of them is going to differ on what truth is. So that's where when I look at this statement in S28, who can disagree with this? I'm just going to read it because I think it's so important. It's actually beautiful. Telling the truth is how trained healthcare providers demonstrate respect for patients, foster trust, promote self-determination, and cultivate an environment where best practice and shared decision-making can flourish. Without veracity in information and communication, it's difficult for individuals to make informed, voluntary choices that are essential to one's sense of personal agency and autonomy. That is a beautiful statement. What I would say, and this is probably because I was trained with the Socratic method, what is truth? And every single one of us is going to go around the room and have different opinions on how we approach healthcare and what healthcare means for us and what we seek out. So as an example, in my practice, I will work with people who find out they have diabetes. Some people are like, give me the metformin, bring it on. I'm not going to put much time into changing my lifestyle thing. It's not my thing. I want the medication. Other people are like, no way. I don't want the medication. I'm willing to do whatever. I am going to watch my carbs. I am going to lose weight. I'm going to exercise, etc. We need these options, and we need providers who present and allow for these options in practice. And that is where I struggle with this. Who's defining truth? Is the Attorney General going to be the one who determines truth when somebody has an issue? If you have an issue with the doctor and you don't feel supported, you have multiple other options, fortunately. You can go find and seek someone who's going to support your path and where you're at and making sure that your comfort level around health choices is there. And that's where I feel like this, with many of the healthcare practitioners that I work with and have talked to, have concerns around obviously Act 15 has to be corrected. It's stayed right now, but it was being litigated because of free speech infringements. This obviously is the attempt to try to fix the problems with Act 15, right? So now instead of targeting pro-life, limited services, pregnancy centers, they broadened it out to all persons. And so is this, again, going to limit providers from being able to share their professional opinion just because it may go against the sort of mainstream, this is what you're supposed to say, this is what you're supposed to do. I just want to share a few other pieces. My mother, this is heartbreaking for me. She has had 7 COVID shots. Since then, she has breast cancer, Parkinson's, and peritoneal cancer. She's now been told by her doctors, you should never get a COVID shot again. I wish somebody had given her a true benefit risk analysis about the COVID shot. It breaks my heart. Since COVID vaccines, prior to them, I had around 94 or so people who were vaccine injured. That has now doubled for me. There's benefit and risk to all medical interventions, procedures, prescriptions, and we need to really make sure that we are honoring a person's decision to make that for themselves, to be informed, to get all the information that they can, and then be able to make that decision for themselves. I'm sorry, talk about my mom and that happens. So this is where I think the concerns come from. There's nothing in here about intent, but we have to recognize we can look back in history how many times science has gotten it wrong. I mean, look at Vioxx, right? Look at thalidomide. Look at DES. Look at DDT. We used to spray kids with DDT thinking that that was okay. Science has gotten a lot wrong, and there's going to be some providers who just embrace the newest technology and the science and go, boom, look it, this is what we have for you. You can do this. And that's a person's choice. Sure, I want to do that. Other people are going to go, I think I'm going to give it a little time. And other providers are going to go, I think I'm going to give it a little time. Let's just see what happens. And this is where I feel like there are a lot of concerns that this broadens it out to persons. And how is that going to limit a provider who has good intent and wants to practice to the best of their ability? How is it going to affect their ability to share their experience, their truth, and to really work with one-on-one with somebody? So I think that's the concern that comes from this bill. The other thing that I would just say, if you can, I really, really hope that you can hear from David Herlihy, who gave testimony. He's the executive director of Vermont Medical Board. He gave testimony in Senate Health. And I did just want to read his quote. I'm hoping you guys will be able to get him in here. When he presented testimony, they had a really big issue, the Vermont Medical Board in general, with Section 3. And I just want to read, they passed a motion on Section 3. Section 3 creates a carve-out to the statutory standard for prescribing via telemedicine. The current law is consistent with the board's long-standing position that it's unacceptable for a prescriber to rely on only a questionnaire when prescribing by telemedicine. The bill proposes to amend the law by adding an exemption that would apply to only prescriptions and drugs to terminate a pregnancy. The board opposes that provision because board members believe that prescribing by questionnaire alone with no interaction between the patient and the prescriber does not constitute quality care. So that's another aspect, and hopefully you can hear from him directly. He also went on to say, and I'm sorry, this struck me because I was in there and I just have to share this last quote, and I'm hoping he'll share it with you directly. Quote, after 30 years of providing testimony at the State House, this is the first time I've ever seen a bill that has such an obvious conflict between the legislative findings made in the bill to cultivate an environment where best practice and shared decision-making can flourish, and something the bill proposes to do, which is just to prescribe by questionnaire alone. So that's another aspect getting into quality of care. Obviously, you can hear from him. But I think the biggest thing that I would say is just, I feel that most people are open to this and they want to create an environment in Vermont where people have options for care. And some people will go more the natural path. All of my kids were born at home. My husband made me go to the doctors at the hospital and say, Allison, do you want to have the kids here? Walk around with me. Do you want to have the kids here? And I was like, no, my comfort is at home. I want to have a home birth with my babies. And people feel very differently. So again, I'm just encouraging, we need options. And I feel like this is going to limit options. It's going to stifle speech that needs to be put out to the public so people can make informed decisions. That's what I'd like to share. And thank you.
You.
Yeah.
Question.
Thank you.
Great.
Thank you very much.
Thank you. Next up, we have Linda Prine. I think, hi, Dr. Prine.
Hi, everyone. Thank
How are
you.
you?
Can
Thanks
you
for
hear me?
joining us today.
Hi. Can you hear me okay?
Yes.
Thank you so much for having me. I'm really pleased to be here and to be able to talk to you about S28, and hopefully I can explain some of the provisions that people have challenged. I'm a family doctor, and I've been providing healthcare for 35 and some years, abortions for about 30 years, and abortions with the pill for about 25 years, very shortly after the abortion pills were approved, which was in September of 2000. My family medicine practice started allowing us to provide pills to people in our offices. From there, I went on to work in a practice in New Mexico, where we provided pills by questionnaire over over an online system. And then I began to work a couple of years ago for Aid Access. When New York State passed its Shield law, I began to prescribe to people in all 50 states. So I have a lot of experience with this, and in all kinds of venues. I've also provided in a Planned Parenthood and continue to provide in the Planned Parenthood of New York City. I'm licensed in both Vermont and New York, and I'm very interested in working in Vermont, where many of my family members live. And I have not been able to do that because of the wording of your previous Shield law. So the way we provide at Aid Access is that we do use this dynamic questionnaire, and we find it very patient-centered in the sense that people know what they want when they come to us, and we are able to quickly provide them with this questionnaire and quickly get them their medications. There's a time issue around this care that is different from mostly everything else. If we were to have a face-to-face video conference with every person that we send pills to, that would, for example, I can sometimes provide pills to maybe 50 or 60 people in a day. If I needed to meet with each of them, that would delay care, because you could maybe see 20 people and you'd have to arrange all those visits. It would make the care more expensive. It would mean that we had to set up all of these video visits. The thing about what we're doing is that it's extremely efficient and it keeps the costs really low. And people, honestly, people who come to us for abortions, they have thought about what they want. It's very paternalistic to think that you need doctors to meet with you first to be sure what your choices are. For example, if a patient comes to me who's pregnant and wants to continue the pregnancy, I don't say to her, well, are you sure you really want to be a parent? Have you considered abortion? Right? I mean, that's not the way it works around decision-making around people's pregnancies. We are not there to tell people or to suggest to people that their decision-making is wrong. Now, of course, if somebody wants to talk it through, we are totally available to talk this through and to provide all of their options and so on. But we're not going to force that on people, especially in a situation where it would delay their care. And the later that people use the abortion pills, the complications do rise. Now, complications are extremely, extremely rare with these pills, but everybody wants to do this as early as possible in their pregnancies. So it would be very unkind to add on to this process a delay so that they had to meet with everyone first. Now, all of the Shield law prescribers, and I am in touch with all of them because we have a group called the Abortion Coalition for Telemedicine, and we meet regularly. None of them use a video visit to do this care. And this has been going on for almost 2 years now across the country. We're getting pills to people in all 50 states. And there are not issues with not having provided an in-person or a video visit. And even in that case in Louisiana that was cited earlier, first of all, those are the facts as described by the Attorney General of Louisiana. Those are not actually the facts. And I can't, it's my partner, Dr. Maggie Carpenter, who's being accused in this case. So I can't really talk about it in terms of what I might know, but I can tell you that those are not the facts. And had she had a video visit with the mother, that would not have changed anything. She could have still sent the pills to the mother, right? But anyway, the idea that a video visit is going to make all the difference is just, it's not true. So in going on, I want to just reinforce that these pills are extremely safe. We've used them since the year 2000 in our country. And obviously, if there were major problems with it, we would be hearing about it all the time. And it's not the case. They're extremely safe. We do make ourselves very available to people once they get their pills. All of the Shield Law providers have an on-call system where people can reach us by phone literally in minutes, which is different from most other medical care. I mean, how many of you can reach your doctor in minutes when you might need to talk to them about something? But we have a phone number that we personally answer when we're on call, and we talk to people whenever they want to. So you can call it abortion exceptionalism, but it's exceptional on many levels. It's exceptional in that we get the pills to people quickly. And then it's exceptional in that we are very available to them if they need us at all as they go through the process. So I think we're providing excellent care. I think the studies support this, and I know that the studies support this. This pill is more studied than any medication I have ever seen in my whole career. It took us many studies just to get it past the FDA. The FDA revised the protocols on it 5 times since it was approved in 2000, with additional studies after study after study that enabled the FDA to change the recommendations because it was over and over being shown to be so very safe. And finally, we come to a place where half the country practically has no availability for abortion whatsoever. And because we can compassionately provide this care through telemedicine, we're able to reach these folks who, I'm telling you, are the poorest of the poor. They are people who can't afford to travel, people who live in remote areas of the country, who can't take off from work, who have kids already. And we are helping them to have the family size that they want to have and the futures that they want to have. And many of them never had this before. There's actually been an increase in access since Roe fell because of this innovation of doing telemedicine abortion in this way. So we are meeting a huge need of people from all parts of our country. And I hope that Vermont can come forward and join the other 8 states that are doing this care, because I would like to live there in Vermont and be one of your providers. So I've got grandkids there. So that's my story, and thank you for your time.
Thank you. Brian, did you have questions?
I do have a question. You were mentioning, I'm sorry, I'm just feeling a little under the weather. You mentioned that that with this medical intervention, that because there was a term you used, exceptionalism, and I was taking that as that some people probably are saying we're making an exception with this particular kind of medication that we don't make with others. But I am curious, is that true? Like, are there other examples of a medication where providers are responding with such urgency and making such an effort to get it to them within a certain amount of time due to the sensitivity of time? Are there any other examples in our medical system similar to that? Thank you.
Yeah, I can't think of any, to tell you the truth. I mean, it might be the case that with some of the addiction medications, and I'm not an expert in that, so I don't know, but obviously if somebody is trying to get off street drugs and they're trying to get buprenorphine and get treatment, there may be some ways in which that is expedited as well because of the dangers of withdrawal and the need to get the the right kind of medicine to that person. I'm really not sure. That's the only instance where I can think of that you might want to make an exception like that, because that's, again, a medicine that's very safe and is life-saving for people.
Thank you. You actually made a good point there. I just want to highlight, which is that I think buprenorphine, like the state of Vermont made it, we decriminalized people just giving it to each other because of that reason. And then we also allowed doctors to start people on it in emergency rooms for that reason. So that is a good example, actually. And it made me think of another one, which it may not be the same because you're the doctor, not me. I'm a clinical social worker, but which is that if someone, I was taught first aid, if someone was having a heart attack, if you think they're having a heart attack, give them an aspirin to chew immediately before you even call 911, because of the, and maybe you could say more about that, but like, that's another example I thought of when you were talking, because I'm just trying to think how it may not be so exceptional. You know, that there might be some other examples in medicine where we do respond with the same urgency. That's what I was getting at with the question. I'm trying to understand it better. But can you say something more about the aspirin piece? Because I'm not the doctor and you are, and I'm not the witness.
Well, you're right that that is a recommendation, and that's a recommendation that even lay people are supposed to adhere to. So yeah, medicine isn't really one size fits all. And so I do take issue with the medical society saying that that people need to have some kind of in-face interaction. There is nothing to be gained that I can figure out from having looked at somebody on a video camera before I send them these pills. You know, I can read their questionnaire. It goes back and forth. If one answer happens that sort of kicks it out, we'll either be asked to look at it, or they will answer some other questions to clarify. That can be done with the technology that we have these days. And we need to take advantage of that in medicine. We are looking at a future where our budgets are going to be cut drastically around providing medical care. And we need to think about how to make it more efficient. We are either going to be in a position of giving less health care to the most vulnerable people and continuing to provide good health care to the rich, or we're going to figure out how to streamline healthcare so that everybody can have a shot at it. So this is an example of wonderfully streamlined healthcare that is very inexpensive because we have cut out the unnecessary items. And I think we can learn a lot from our experience with telemedicine abortion in the coming years as we try to figure out how to provide healthcare for much less money, quality healthcare. And we're doing it with abortion care. We're providing really good care to people. And that's really the wave of the future.
Mari, did you have a question?
Yes, Dr. Prine, do you have comments about what was mentioned earlier about the abortion reversal pills?
Sure. That is such a scam. I'm sorry, but those studies were retracted from the few legitimate medical journals where they were published. And the reversal actually puts people at danger. Taking those medications has been shown in what was going to be a regular randomized controlled trial, that they had to stop the study because so many people in the reversal arm were hemorrhaging after they got that treatment. So it's not only not an acceptable form of treatment, but it's a dangerous form of treatment. And you know, it's totally been discredited in the mainstream medical world. And the American College of Obstetrics and Gynecology has written about it, and so has the Society of Family Planning. All the mainstream medical organizations will tell you this is not a safe practice whatsoever.
Thank you.
Thank you. Woody?
Just a couple things. Is it possible that we could get a copy of this questionnaire that I hear everyone talking about?
There was a link yesterday. Oh, yes, Jessa's testimony.
Okay.
But we could ask for another one.
Yeah, there's a link. I'll send it to you.
Okay. And then the other question is, these abortion pills, how long in your pregnancy are they effective? At what point
Yeah.
are they not effective?
Yeah, that's a really good question. It turns out they are always effective, and the pill mifepristone is used throughout pregnancy, but under different circumstances, as is the other medication, misoprostol. They're used to help with inducing a patient who needs to have a delivery at term even. They're used in the second trimester under, in hospital settings when somebody is having an induction for, say, fetal anomaly or something. And then they're used in the first trimester to induce an early abortion. So these medicines are part of our bigger picture of medications used in the labor and delivery arena. They're listed by the World Health Organization as essential medicines for care. If your question is really just about how many weeks in a first trimester pregnancy can they be safely used, the World Health Organization says up to 13 weeks.
And I guess as you as a doctor would advise other medical treatment after that period of time,
Well,
rather than issuing a pill.
Yeah, we don't send the pills after 13 weeks, although there are community sort of semi-underground community groups that do send them later in pregnancy because people are just that desperate, but mostly a procedure is recommended if it's after 13 weeks.
Thank you.
Easy. My question was along the lines of Woody's question, just related to, I guess the impact on patients and what their experience is. And I know when we're talking access and improving access and, the benefit of having that to these medications, some of us deeply appreciate that. And I wonder if we can just talk a little bit about, the average patient that you're working with. I don't want to speak too much from personal experience, but I know sometimes, people need these medications, the day of an incident, right? And so it's not like people are sitting around and going, oh, I'm kind of tired of being pregnant. I don't think I want to be pregnant anymore. It's not like these are typically used late stage. And so I wonder if you can speak to the incident, sometimes traumatic, in which a pregnant person might need these. And what stage do you typically see patients come to you?
So most of our patients are applied for these pills when they are under 6 weeks from their last menstrual period. Like you say, people know, women know in their mind before they even miss their period what they would do if they found themselves pregnant. Most people have an intention one way or another about what they want. And the slip-ups when they find out they're pregnant, they kind of know already, oh, this is not good. This is not what I wanted. And unfortunately, if they live in one of these states where abortion is illegal, they don't always know how to get the information to get pills online. And so they start with Google, and people find us from TikTok and Reddit and Facebook and all kinds of ways, but it can take them a while. And that's where sometimes we find people later on in pregnancy, or, even in the first trimester, 10 weeks, 11 weeks, because it's taken them weeks to find the resources. And that's something we're working on changing, but some of these websites keep taking down. Instagram takes down the aid access information over and over again, and we have to challenge them and go back. So it's a rough world out there trying to get the word out about the availability of these pills. And that's partly why we want as many states as possible to be offering the care so that we become a critical mass and they're just more and more available. I'm sort of rambling here. I'm sorry.
A follow-up to that, can you speak to if there are women who have been raped or something like that, that maybe they don't know they're pregnant? Like, I'm from Alaska, where, clinics are a flight and a drive away, hours away, that costs $900 to get to a provider.
Yeah.
If someone needs this medication there because they've been raped, they are able to phone a provider and get it delivered to them by mail within 2 days.
Yes.
And that is a crisis response in my book. And I just want to be sure that folks know that women aren't sitting around pregnant and just deciding that it's going to be too difficult. Sometimes it really is a crisis response matter.
Yes, that's exactly true. And we do, we do offer resources when people, in our questionnaire, that's one of our questions, is this pregnancy the result of rape? And we do send people resources for counseling and support and all of that as part of our protocol. But it's shockingly not as rare as one would think. I've been really amazed to see how often the answer in our questionnaire is yes. There's more versions of coercion than you can imagine, boyfriend coercion, husband coercion, relative coercion, that have caused these pregnancies. And like you say, it's urgent. And somebody has gone through that and they want to not be pregnant. The urgency of that issue is profound.
Any other questions? I had one. I wondered if there is a piece of this bill that around removing a provider's name from a prescription. I wondered if you had any other experience with that in other states, because
yes, thank you so much. That's one of the most important parts of the bill, and I forgot to even mention it because I was going off on all these other things. Yes, Washington State was the first to pass that law, and then New York State very recently. The reason this is so important is that my colleague Maggie Carpenter, who is the one being sued by the state of Texas and by Louisiana, they found out that she was a prescriber because of the pill packaging. A boyfriend in Texas searched through his girlfriend's garbage and found the pill packages. She hadn't even told him that she was having an abortion. And he took those pill packages to Ken Paxton, the AG of Texas, and that's how they went after Dr. Carpenter. So, we wish we would have thought of this 2 years ago when we started this process and gotten that in all of the SHIELD laws. But it's very urgent to do that now. And the most urgent state is California, which is where the pharmacies mail from. So we really need to get the labeling changed in California, but it has already passed in Washington State and New York, and it's before many of the other state houses that have SHIELD laws. We're hoping to get that fixed. So
pharmacy, it's happening now, and pharmacies have the capability of removing the name from the prescription.
Yes, they just.
I think we're getting some conflicting information.
Yes, there's a code for each provider which they keep, and so that if they ever needed to match it up, that information would be available. But it's not on the patient's package.
Thank you. Mari, did you have a?
Yeah, just to follow up on that, we're hearing from pharmacists in Vermont that the systems that they use to label medications, it would not be possible to remove the physician's or the provider's name from the prescription label. So that may be a question that we could reach out to other, like Washington State, and see how they did it.
I'm not sure why they find that challenging, because other states have been able to do it. But to be honest, the SHIELD law providers are using mail order pharmacies. We're not using local pharmacies. The places where that would be hard would be if a provider is in Vermont and their patient has traveled to them and they're going to travel back to a state where it would be dangerous to be holding those pills. Those providers having their names on the pills would be the ones at risk. I don't know if Vermont actually has local pharmacies that are dispensing mifepristone and misoprostol, the two abortion drugs. Many states don't in reality have brick and mortar pharmacies that are doing that. It's mostly the mail order pharmacies, and they have not had a problem with taking our names off. So you can ask the ones in Vermont, but they may not be the people who really need to do it in any case. It's that the Vermont providers need to have that permission so that when they send the prescription to the California mail order pharmacies, they can have their names left off. It's
Dr. Johansson, did you want to weigh in on that?
one more instance I want to just tell you about would be if a Planned Parenthood wanted to leave their provider's name off if the patient traveled. Lots of the people who are coming from the South are going to cities where they have relatives so that they can get their care in a safe state and stay with relatives. So if someone were to fly to Burlington and get there and wants pills, because they don't know they could get them by mail, and they get them at the Planned Parenthood, and then they fly home with their pills, Planned Parenthood would also like to be able to leave those names off because it puts their providers at risk. So all of these instances, we really do need that option. I mean, it's if somebody wants to leave their names on, that's fine. But if they want them off, we need the option to protect the providers so that they don't end up in these lawsuits like Dr. Carpenter is in the middle of.
Question.
Woody, Dr. Johansson, did you want to weigh in? You had your hand up for a while.
I've been dying to add in, but I had it in myself, but Linda has answered everything.
Okay, great.
You know, I concur with everything that she has said because it's all basic information. And again, we do all know each other. It's a small world of shield law provision and telehealth across state lines. Yeah.
Okay, Woody, you had.
Yes.
Let's do one last question for Dr. Prine, and then we'll move on to Dr. Johansson.
If we can get these pills, online and order them, I'm assuming we don't need a physician to prescribe it. Is that correct?
No.
You have these.
This is a prescription medication. You would have to have a
You
prescriber.
have to have it, okay, even online.
Yes.
Okay. That's my question.
Actually, that along the lines of the question, I know I said that was the last question, but Brian had kind of asked this, and maybe it's indicative of how much streaming services I watch television, but the concern over the interactive questionnaire, aren't all those advertisements for like Hims where you can get erectile dysfunction prescriptions, aren't those all interactive questionnaires?
I don't really know, to tell you the truth. I'm not part of that world.
I mean, it's my understanding that it's just a website. You go and you fill out a thing, and then a doctor somewhere who has a contract mail orders you your Cialis or Viagra or whatever. They
You're right.
determine with the questionnaire you need, which one.
Because there are also hers.
Yeah, there's a hers too, which, and I think so there's lots of.
And that is a much more dangerous drug, I might add. Viagra is a much more dangerous drug than mifepristone, just saying. People get heart attacks and die from Viagra. So that's probably not mainstream medicine to just send it to anybody.
Yeah. Okay, thank you. Dr. Johansson, welcome.
Well, hi, thank you for having me on such short notice. Anyway, I wanted to add, there was a question about getting pills online. I don't know the gentleman who asked just a moment ago.
Representative Page, Woody.
I just wanted to let you know that people can get pills online without a prescription. They can contact pharmacies directly and get pills from India or sometimes Mexico. Those would not be FDA approved medications, but they can get them without directions, without information, without filling an online questionnaire. And they just go it entirely alone, though they can usually find help to help them in that case also online with people who are willing to help them. I just wanted to clarify that. So without any medical screening whatsoever, we do provide medical screening, and we do provide follow-up, and we do provide being able to ask any patient's questions with regard to those questionnaires.
I just wanted to clarify that. Hi, I'm Renee Johannesson. I am a board certified OBGYN. And I've been providing abortion care for at least 25 years, both nationally in many states and including internationally, working with groups in certain African countries. I've been at this a long time. I've been a long time generalist OBGYN, but have found the provision of abortion care to be incredibly vital in people's lives and in the lives of women and families. And somehow I ended up becoming more of a specialist in both providing education and direct care to patients in family planning. I'm going to read a little bit of my testimony, and I'll take any questions after that. Anyway, I did start a telehealth practice in 2023 in Vermont, very specifically anticipating the passage of Shield Law legislation, which Vermont did in 2023, in May of 2023. And this was after the 2022 Dobbs decision that closed reproductive health centers. In fact, it closed the center that I was the medical director at in Montgomery, Alabama. I do think I was the only Vermont Shield Law provider at any time. And I had to stop practicing because of the language in the statute that S28 is trying to eliminate, which is the wording between synchronous, asynchronous, static versus not static versus in-person care. And the thing is that Vermont is kind of exceptional in that they were still demanding this synchronous visit. And if you looked at the telehealth regulations for all medical boards, that's not a provision that is in all states, but it is in Vermont. And in fact, even New Hampshire got rid of it. So Vermont is a bit exceptional in that they don't allow it under certain situations. I just wanted to be clear about that. Also, complete asynchronous care has not been shown to be less safe at all. There's lots of peer-reviewed studies to show provision of care completely asynchronous, and especially with a dynamic online questionnaire, is just as safe for all of the reasons that Linda Prine talked about. Me talking with somebody on the phone or with a virtual visit, it isn't going to change what they have already provided to us. People want to be safe. People don't want to try to get away with something and be unsafe. They actually want our input that they're going to be okay during this process. And most of the time, there isn't any reason or anything that would stop us from providing that care. There's very few exceptions. There's very, very few contraindications. There's very few absolute contraindications. So why slow down the process so we could say, oh, this is what you want? Yes, okay, thank you for your visit. And that takes a lot of time. It takes a lot of effort. It takes a lot of money to make that unnecessary synchronous visit happen. And it doesn't provide increased safety. I mean, that's clear from what we're experiencing on the ground and also from what we see in the medical literature. The funny thing is when it comes to medical literature, once something is out of the bag, it's hard to put back in. So for instance, this thing with the abortion pill reversal, that has been completely debunked by one of the best researchers in this field. They had to stop the study because the people who were taking the medications to reverse the abortion pill were actually getting in trouble and having much more complications. It's kind of like vaccines causing autism has been totally debunked, and you just can't get rid of that. And it's leading to lots and lots of problems. So this idea about not telling women and giving them options about doing something that's actually dangerous and debunked is not beneficial to anybody, especially to the person seeking care. I will go on. Another reason why it might be difficult for some people to do the synchronous care is because they might be in really difficult situations. They might have to try to find time from work to pick up the phone and get online with us. They might be in an abusive situation where their partner won't let them get on the phone and monitoring everything they do. So there are times when it can't happen. And certainly if a patient wants to talk to us, we're always available. If they write, I filled out this questionnaire, but I really want to know if this is safe. I want to understand more about the procedure. We're available 14 hours a day. There aren't too many practices where you can pick up the phone and call us and get somebody within a half an hour to ask even basic questions or to verify their care or to verify if they're a candidate. So the idea that we're just sending out prescriptions without patients being able to follow up with us it's not the case, but it's giving patients the option of streamlining their care versus getting bogged down for no good reason. And in fact, if anything, we've seen gestational ages going down because people do know about us. People have found our services. And in fact, sometimes they're so early, it actually almost makes it more complicated because we're like, oh, so you're like, you missed your period yesterday and you have a positive pregnancy test today. And so they're getting their pills really, really early. Sometimes we say, maybe you want to wait a week and, see if that pregnancy test stays positive since it's so faint and early. So there's a lot of nuance that actually happens with the provision of our care. It's not, here are your pills and see you later, which you can get, by the way, online. So of course, this is a healthcare emergency. In states where there are bans, if women don't have abortions available to them, we know from literature and demographics all over the world that maternal mortality and morbidity goes up. Texas, I believe, has stopped even gathering information about maternal mortality because they don't want to know. Because we know that there is no safe obstetrical care without the ability for safe abortion care. They cannot be separated. There will always be time in obstetrical care in wanted pregnancies where the need for an abortion comes up. Either something goes terribly wrong or somebody has cardiac disease, they shouldn't be pregnant. And again, you cannot separate the two. If you look all over the world, when you separate the two is when you start to endanger women's lives and their health. The US already has some of the worst maternal mortality in the entire developed high-income world. It is abysmal. We're probably at the very bottom. And by banning abortion in certain states, we're only going to make it worse. And the one thing we can do in Vermont and New York and other shield states is try to counter those grim statistics by providing necessary care to women who desire necessary care. Nobody has to have an abortion. Nobody's being coerced into having an abortion. They're making determinations, for themselves. And we know the long-term outcomes very well. We know that people who need to have an abortion, their outcomes are worse, their family situations are worse, their children do worse. Most women who have abortions already have children that they're caring for. And there are plenty of studies I can provide you, long-term studies to show that when people are unable to get the abortion they deem necessary, the outcomes on many measures are worse, not just for the person in question, but for their entire family. In fact, a medication abortion in the first trimester most people don't know this, is 20 times safer than attempting to carry a pregnancy to term. It's just a simple fact. And again, like Dr. Prine said, when somebody comes in for their first prenatal visit, we don't say, so it's very, it's really dangerous to be pregnant. Do you want to consider an abortion? But yet when people decide to have an abortion, which is a safe option, we don't tell them, wouldn't you rather be pregnant and, carry these safety issues? We just don't do that. With regard to the names being on the pills, by having a prescription, it makes it safer for patients in states that have bans to actually have a prescription from a physician. And that there is a way that we can prescribe this so that it is safe for them to possess it, makes it safer for them too. It's not just for our safety, it's for their safety too, that they're getting an actual prescription. And it is for our safety too, because, let's face it, we go on we take a lot of personal risk doing this work, and we'd like to decrease that personal risk any way we can. There's no benefit for putting us in danger and getting more and more people not to provide this care. We'd like to see more people providing Shield Law protection. Prescriptions, not less, because there's so many people in need, and we'd like to spread out the risk. If there's a lot of us providing the care, there's a little bit less risk to any one of us, and physicians aren't going to be providing this care if the risks are constantly present. I think that's all I have to say. And I'm open for any questions.
Thank you. Any questions for Dr. Johansson? All right. Well, thank you so much. Thank you, both of you, for joining us today. I think we are going to take a break. Since we have legislative council, how about we come back at 10:25? All right. Thank you. We can go off of